Dr. Ashneet Sandhu. She will talk about our experience of pneumatic retinopexy in Rhegmatogenous retinal detachment. Dr. Bandana, are you going or you can join here, please? Please join.
Good afternoon, everyone. I'll be talking about our experience of pneumatic retinopexy and rhegmatogenous retinal detachment. So what basically is pneumatic retinopexy? It basically involves sealing of the retinal breaks with introduction of an intraocular gas bubble, which remains long enough so that the subretinal fluid is absorbed and the chorioretinal adhesion occurs around the causative break or the tear. So it has been demonstrated that the rates of final reattachment were comparable to those of scleral buccal and pars plana vitrectomy. So it's an outpatient procedure with comparatively less complications. So the aim of a study was to see the visual recovery in patients and to assess the success rate following pneumatic retinopexy. So 25 patients were taken over a period of 6 months, and the patients who were eligible for pneumatic retinopexy were those who had a single or a multiple contiguous breaks which were positioned from 8 to 4 o'clock hours. And we need to keep in mind that a clear optical media is very important for a good retinal examination. The patients who were excluded were those who had a lattice degeneration outside the quadrants, usually the inferior breaks or inferior lattices, who had PVR changes of grade C or more, and who were unable to maintain a post-operative head positioning, and known cases of glaucoma. So the technique, it was a one-session procedure with informed consents were taken from all the patients. A peribulbar block of 2% xylocaine was given. The eye was cleaned. The cryoprexy around the retinal holes were done. An anterior chamber translimbal parasynthesis was done, and 0.6 ml of SF6 was injected. After the injection, a chorioretinal perfusion is very important to be checked, and the patient is counseled about the positioning of the head. That is, the supine position should be maintained for a minimum duration of 6 hours post-surgery, and thereafter how long he can maintain it. So these patients were followed up on day 1, 3, 5, and 15, and later monthly follow-ups were done for 3 months and 3 monthly for 6 months. So on every visit, the visual acuity, intraocular pressure, and a retinal examination by indirect ophthalmoscopy was done. All the patients were administered Diamox for 2 days post-surgery, and wherever needed, retinal laser by ILO was done, usually on day 3. So the fundus diagram is very important to be made in all the patients by indirect ophthalmoscopy. So this is a patient which is showing a left eye. There is a horseshoe tear present, resulting in a retinal detachment. So another patient had a lattice with an horseshoe tear, resulting in again a bullous rhegmatogenous retinal detachment. So there was another patient who had a coloboma and he had a horseshoe tear which was present. Again, pneumatic retinopexy was done and the results were achieved. There was also a patient who had a giant retinal tear and he had a very shallow RD. So we went ahead and did a pneumatic retinopexy, and the results were good in this case also. So talking about the results, the mean age which was seen was 47 years, ranging from 21 to 78 years. Most of the patients were male. Right eye was most commonly involved in these patients. Most of the patients which taken up for surgery were, for pneumatic retinopexy, were phakic patients. And they had an extent of retinal detachment. Most of them were between 3 to 4 o'clock hours, that's 36%. And majority again had a macula-on retinal detachment. So the number of retinal tears usually in such patients, there were horseshoe tear, which was usually involving only a single tear was present, which resulted in a rhegmatogenous retinal detachment. So the visual acuity which was seen was on of day after 2 weeks, it was seen that 60% showed an improvement in at least 2 Snellen lines, and there were 8 eyes which had no significant improvement in the visual acuity. So the success rate which was seen was that 72% had a single operation success rate. The 5 cases required vitrectomy with silicone oil injection, and 2 cases underwent a belt buckle. They were usually the patient who had a prior implantable phakic contact lens inserted in them. So it was also seen that the phakic eyes had a better result than the pseudophakic eyes. Complications which were noted during our procedure was there were anterior chamber gas migration, subretinal gas migration, resulting in a retinal detachment in 28%. Similar results were also seen in the other studies which have been conducted in the past years. So to conclude, pneumatic retinopexy is a safe, low-cost, a well-tolerated outpatient procedure which is usually underutilized. Successful outcome is primarily dependent upon a thorough retinal examination, wherein we have to identify all the breaks with an indirect ophthalmoscopy. So the patient selection is very important before going ahead with pneumatic retinopexy, and it can be a first-line treatment and a non-surgical alternative to scleral buccal or pars plana vitrectomy in patients who have an uncomplicated superior rhegmatogenous retinal detachment. These were the references. Thank you.
Thank you. Obvious. So choosing for retinopexy, the patient selection is very first and foremost criteria.
Patient selection.
So what is your selection criteria?
Ma'am, usually they were young patients who did not have a proliferative retinopathy changes. PVR changes we have to exclude because that will usually result in the failure of the gas bubble. And another thing is the patients who had a superior, that's 8 to 4 clock hours, rhegmatogenous retinal detachment is important for the breaks to attach.
Obviously, because if you don't have a setup also initially, you can try this. If patient selection is good and patient is a good candidate, later on if you don't succeed, you can refer for surgery. But obviously, thank you.
Yes.
You can discuss something, Dr. Vandana also.
Very nice set of cases. Actually, I am interested in the one that you were talking about, the giant retinal tear.
Yes.
So you talked about
it had a very shallow rhegmatogenous retinal detachment.
So was it successful later
on? It was
on?
successful. The patient's vision improved.
So which were the ones that you said that like few of them, that failed, like
they were usually, ma'am, patients who were mostly old age, unable to maintain a post-operative head positioning, although they were counseled, because there was 2 patients who were above 70, but because it's a low-cost procedure, they could not pay well, and they did not want to undergo the exclusive surgery, so we had gone ahead and done the pneumatic retinopexy, but it failed, so we again went ahead and did a pars plana vitrectomy for them.
Okay, thanks.
Thank you.